Hi, my name is Terry Duran, and we have several objectives of this module. We're going to discuss common emergencies of geriatric residents and how to prevent them. We're also going to discuss how to recognize sudden changes in physical condition and how to initiate emergency treatment. As a worker in a long-term care facility, you may be the first person on the scene at a medical emergency. You may witness somebody having a stroke, having a heart attack, or suffering a seizure. Being able to recognize common medical emergencies and deliver the proper first aid in these situations are important skills. The interventions that are outlined in this teaching are basic, but it is information that many people don't know, and the techniques you will learn can be life-saving. So, we are going to look at basic scenarios and how the healthcare workers should respond in each situation. But first, we're going to discuss some basic principles. The first principle is help. In many of these emergencies, such as a cardiac arrest, the first thing you need to do is get help because you cannot provide adequate care by yourself. Also, if you are simply unsure, call for help. Number 2 is safety. This refers to both the resident and the rescuer. One of the primary rules in medicine is first, do no harm. And one of the primary rules of an emergency response is don't make more victims. Don't do anything that will harm the resident, yourself, or someone else. The third principle is organization. Stay as calm and organized as possible. There is almost always more time than you think, and much of the pressure of an emergency is the pressure you place on yourself. And check vital signs if appropriate. You can check the blood pressure, pulse, respirations, and even the oxygen saturation. It's also important to know the resident's advanced directive. All residents in the long-term care facility should have an advanced directive already in place. These advanced directives help reduce confusion and disagreements about medical care. The first part of an advanced directive is a living will. It states the resident's wishes regarding the care they want to receive if they are incapacitated. And it helps decide what medical interventions are acceptable and whether the resident wants his or her life extended if there is no hope of recovery. A living will typically cover situations involving resuscitation, mechanical ventilation, tube feeding, etc. The second part of an advanced directive is the medical power of attorney. This is a legal document that allows the resident to designate someone to make medical decisions for him or her if they are unable to do so. It will be important to contact this person in the case of a medical emergency. The third portion is a do not resuscitate order, or a DNR. A DNR order is created or set up before an emergency occurs. And this order allows the resident to choose whether or not they want CPR in an emergency. And this is simply specific to CPR. It does not have instructions for other treatments such as pain medicine or medicines or nutrition. The doctor only writes the order after talking about it with the patient, if possible, or the patient's family or representative. So again, in emergency response, stay with the resident and call for help and be sure that the nurse is notified. Do not move the resident unless there is immediate danger. Remain calm and reassure the resident. Start emergency measures that you are trained to perform while waiting for help to arrive. Remain with the resident after help arrives to assist and answer questions as needed. Know the facility procedure and phone numbers for reporting emergencies, and know where emergency equipment and supplies are located. So now let's go more into specific issues. The number one issue we're going to talk about is falling. So let's look at some of general facts about falls in adults 65 years of older that simply live in the community. So falls are the leading cause of death and non-fatal injury anyway in adults 65 years and older. It can result in decreased functional independence, significant disability, and reduced quality of life. And 30 million older adults fall each year, resulting in about 30,000 deaths. 1 out of every 5 falls causes serious injury, such as broken bones or a head injury. Each year, at least 300,000 older people are hospitalized for hip fractures, of which 95% are caused by falling. Now, if we look at facts about falls in the long-term care setting, about 5% of U.S. adults aged 65 and older reside in nursing homes, but deaths due to falls by nursing home residents make up 20% of deaths in the same age group. About 35% of injuries due to falls occur in residents who do not even walk. The average rate of falls is 2.6 falls per person in any given year. And between 50 and 75% of nursing facility residents fall each year. This is twice the chances of falling if the senior lives in the community. In a typical year, a nursing home with 100 residents reports about 1 to 200 falls, and about 10 to 20% of nursing home falls result in serious injuries. About 1,800 individuals living in nursing facilities die from falls in any given year. So it's important to understand the definition of a fall. The Centers for Medicare and Medicaid Services, or CMS, definition of a reportable fall includes the following: an episode where a resident lost his or her balance and would have fallen were it not for staff intervention is a fall. In other words, an intercepted fall is still a fall. Also, the presence or absence of a resultant injury is not a factor in the definition of a fall. A fall without injury is still a fall. When a resident is found on the floor, the facility is obligated to investigate and try to determine how he or she got there and to put into place an intervention to prevent this from happening again. Unless there is evidence suggesting otherwise, the most logical conclusion is that a fall has occurred. The distance to the next lower surface, in this case the floor, is not a factor in determining whether a fall occurred. If a resident rolled off the bed or mattress that was close to the floor, this is still considered a fall. So let's look at a scenario. You respond to G's calls for help and enter her room to find her on the floor next to her bed. You can see that she has a head laceration, but that she also indicates that she has pain in her left hip. Because of your training, you recognize that she has had a fall and may have a fractured hip. So what is your immediate response to a fall? First, you stay with the resident and you call for help and be sure the nurse is notified. Now, this is not the case for her, but if she had gotten up and had been standing, assist her to lie down or sit in the chair. If she had gotten to a sitting position, assist her to lie down or assist her to bend forward and put her head down between her knees if she's able. But she is on the floor, so don't try to move her until the nurse examines her and she assesses the risk for a fracture and then gives instructions. So observe for and report to the nurse such things as the time of the fall, the cause of the fall, such as wet floors, or maybe her shoes were not on properly, or they were ill-fitting, or maybe her own condition. However, don't speculate on the cause of the fall. Report only what you know to be a fact. Next, measures taken to break the fall and assist the resident if there were any. Any witnesses to the fall? Did anybody see it? Any additional information needed by the nurse to complete the incident report and other significant observations. The immediate evaluation by the nurse after a resident fall should include a review of the resident's systems and description of injuries to identify any clues as to what caused the fall. Risk factors related to medical conditions or medication use may be reflected in abnormal values for any of the following. For example, vital signs, orthostatic blood pressure readings, or even a finger stick blood glucose level, so a blood sugar level for diabetics. When indicated by the resident's condition and history, laboratory tests such as a complete blood cell count, a urinalysis, checking the oxygen level using pulse oximetry, checking electrolytes, and maybe an ECG, so an electrocardiogram should be performed. In some cases, such as a head injury or a possible fracture, EMS will need to be called and the resident transported to the hospital for further evaluation. The second subject we're going to talk about is restraints. When I started working in a long-term care facility, restraints were freely used, and no, I'm not telling you my age. But just like surgeons don't automatically remove a child's tonsils anymore, times have changed, and that's what we're going to talk about. Now, the literature explains different types of restraints, namely physical, chemical, seclusion, and environmental. This is kind of a mouthful, but the Center for Medicare and Medicaid Services defines a physical restraint as any manual method or physical or mechanical device, material, or equipment attached or adjacent to the resident's body that the individual cannot remove easily, which restricts freedom of movement or normal access to one's body. So some examples of this would be leg restraints, arm restraints, hand mitts, soft ties or vests, lap cushions and lap trays that the resident cannot remove easily. A chemical restraint is defined as any drug that is used for discipline or convenience and not required to treat medical symptoms. Seclusion is defined as placing a person alone in an area with the door shut in such a way as to prevent free exit from that area. An environmental restraint is predominantly used to prevent free movement of a person in a building or an area. Now, most often, chemical restraints are used in nursing facilities to sedate and pacify patients whose behavior is too aggressive or unruly for the staff. Now, it is important to understand that when medications are used to treat illnesses or protect the safety of a patient, they do not qualify as a chemical restraint, but the usage of chemical restraints is a violation of federal law. So what can be used as a chemical restraint? Well, any type of drug that has a calming or disorienting effect can be used as a chemical restraint. Some of the most common types of drugs used for this purpose are antidepressants, antipsychotics, mood stabilizer, anxiety medications, and sedative hypnotics. Now, what are the harmful effects and risks of chemical restraints? Chemical restraints are actually incredibly dangerous. Using powerful psychotropic drugs has clear risk to a patient's physical and mental health and should only be used when absolutely necessary. Because the elderly are often taking more than 5 medications already, the risk of harm is greatly increased. According to the FDA, unnecessary use of antipsychotic medication kills 15,000 nursing home residents every single year. The federal government has spent years warning facilities about their dangers, especially the damage they can do to the heart and cardiovascular system of somebody with dementia. But despite these warnings, more than 88% of antipsychotic drugs used in nursing homes are used on patients who have dementia. The risks and harmful effects include increased dependence and functional decline, loss of memory, agitation, withdrawal and depression, orthostatic hypotension where somebody's blood pressure drops, loss of mobility and strength, increased risk of accidents and falls, low blood pressure just in general, muscle disorders, and other adverse drug effects. Physical restraints, of course, are much easier to recognize. Over the last 10 to 15 years, medical research has produced strong evidence that physical restraints do not prevent injury like we originally thought, and may in fact represent a safety hazard for the resident. These findings, combined with a heightened concern about the quality of life in nursing homes, have prompted a re-examination of past practices regarding the use of physical restraints. And now a national effort is underway to reduce the use of physical restraints in nursing homes and seek alternatives to restraints to ensure the safety of residents. There are dangers and outcomes of the use of restraints. Despite standards aimed at minimal or no restraint use, approximately 15% of nursing home residents and 6 to 17% of patients in acute care settings spend a portion of their day in restraints or confined inappropriately by side rails. Among older patients or older residents, the incidence of restraint use is higher. It increases to 18 to 20% among those 65 years or older, and up to 22% for those aged 75 or older. Of older patients who fall, 13 to 47% are physically restrained. Serious injuries from falls are greater when the person has been placed in physical restraints. Among restrained patients, 20 to 50% demonstrate significant depression, agitation, confusion, withdrawal, or anger as a result of restraint use. Also, morbidity and mortality risks are associated with physical restraint. For example, there are short-term complications such as new onset bowel and bladder incontinence, constipation, decreased appetite, pressure ulcers, muscle weakness, injury to nerves and joints, pneumonia, and respiratory complications. However, there can be more serious complications such as death from strangulation, such as head and body entrapment between bed rails, mattresses, and footboard that can occur because persons who are restrained are those with altered mental status, restlessness, confusion, lack of muscle control, or a combination of all. But there are also psychological effects. The adverse psychological effects of restraints include anger, aggressiveness and agitation, demoralization, humiliation, feelings of low self-worth, depression, impaired social functioning and social isolation, feelings of shame or guilt, loss of dignity and self-respect, loss of autonomy. There are benefits of eliminating restraints. It gives the resident greater autonomy and improved quality of life, reduction in the use of antipsychotic medications, reduction in the seriousness of injuries due to falls, and a reversal and improvement of the many adverse effects mentioned because of improved mobility. There are so many alternative measures to restraints, but that's out of the scope of this module. But just know that everybody is concerned with providing safe care for individuals with physical and mental limitations. That is universal. Self-care can be provided without applying physical restraints or chemical restraints, which unduly restrict freedom and create other serious risks. Safe care can be assured through the use of alternative safety measures, which can be tailored to meet an individual's specific needs, ensuring the best possible quality of care. And facilities that have dramatically reduced physical restraint use have not experienced an increase in serious injuries and have seen marked decreases in the incidence of agitated behavior among residents. Reducing the use of physical restraints is a national goal which is being promoted by caregivers from all segments of the healthcare team. The motive behind the goal is enhancing the quality of life of nursing home residents while assuring safety. The payoff will be better and more appropriate health care for individual nursing home residents who will be spared the indignities and harmful effects of restraints. Now we're going to discuss how to recognize sudden changes in physical condition and how to initiate emergency treatment. The first subject we're going to discuss is choking. According to the National Safety Council, choking is the fourth leading cause of unintentional injury death in the U.S. and is higher among the elderly than any other age group. Swallowing is a reflexive motion that requires coordinated muscle performance. That balance is disrupted when disease and age weaken the throat and the esophagus. Choking occurs when a blockage somewhere between the nose and the mouth and the lungs, which is the airway, prevents air from getting into a person's lungs. The obstructions means trouble breathing or no breathing at all, and the person will die if first aid is not given right away. So somebody can be choking but still be able to have that movement of air. So if somebody is choking but can still breathe, then they will still be able to speak. There will be signs of distress. Their eyes will show fear. They'll have a lot of forceful coughing. They will be wheezing and gagging between coughs. Their face will be red. They will be grabbing their throat and they will be drooling. But if they can't breathe at all, they will not be able to speak. Again, signs of distress. No fear. They won't be able to cough, or it will be very weak. There will be a high-pitched noise or no noise when trying to breathe or cough. Their face will have a grayish pale color, and their lips can be blue, or even their ears, and they will be grabbing their throat. Let's look at a scenario. B is a resident with moderate stage Alzheimer's. During the lunch meal, he starts clutching his throat. His face turns red and he is coughing. Because of your training, you recognize that he is choking. So first, you assess him. If someone is breathing and if he or she can cough loudly and can make sounds, do not intervene. Wait and see if the object will be coughed out. If someone cannot cough, breathe, or make sounds, then you will need help. The American Red Cross recommends a 5-in-5 approach to delivering first aid. Give 5 back blows, which means stand to the side and just behind a choking adult. Bend the person over at the waist so the upper body is parallel with the ground, and deliver 5 separate back blows between the person's shoulder blades with the heel of your hand. Then give 5 abdominal thrusts, and this is called the Heimlich maneuver. So alternate between 5 blows and 5 thrusts until the blockage is dislodged. The American Heart Association doesn't teach the back blow technique, but only the abdominal thrust procedure. So it's okay not to use the back blows if you haven't learned the technique. Both approaches are acceptable. Now, to perform these abdominal thrusts or the Heimlich maneuver on someone else, you need to stand behind the person and place one foot slightly in front of the other for balance. Wrap your arms around the waist, tip the person forward slightly, make a fist with one hand, position it slightly above the other person's navel. Grasp the fist with the other hand and press hard into the abdomen with a quick upward thrust as if trying to lift the person up. Perform between 6 and 10 abdominal thrusts until the blockage is dislodged. If you're the only rescuer, perform back blows and abdominal thrusts before calling 911 or your local emergency number for help. If another person is available, have that person call for help while you perform first aid. If the person becomes unconscious, perform standard cardiopulmonary resuscitation with chest compressions and rescue breaths. Now, of course, in the long-term care facility, you will have plenty of help available. The second subject we're going to talk about right now is stroke. Now, strokes are serious and they can be deadly. Being familiar with the signs of stroke and responding quickly can save the older adult's life or reduce their chance of developing major disabilities. Stroke is the 5th leading cause of death in the United States, affecting about 800,000 people each year. It also causes more serious long-term disabilities than any other disease. If a blood vessel in the brain ruptures and affects neurological function, this event is called a hemorrhagic stroke. When a blood vessel in the brain is occluded by a clot and neurological function is affected, this event is called an ischemic stroke, and these types of strokes are much more common. The signs and symptoms of a stroke can happen very quickly and with little warning. The victim may seem confused, they sometimes can't speak, or their speech is garbled. One side of the victim's face can sag or droop. Maybe he or she has serious weakness in the hands, arms, or legs. There is an acronym that is frequently taught, and it is FAST. So if you were ever to see facial drooping, facial sagging, the A it stands for arm, so weakness in the arm. Or if somebody's speech is absent or garbled, then time is of the essence, because the administration of IV medication that can dissolve a blood clot in the brain must be delivered as soon as possible after the onset of the signs and symptoms of a stroke. If this care is given promptly, brain tissue can be saved and brain function preserved. If there is a delay in treatment past 60 to 90 minutes, the risks of a bad outcome increase significantly. So let's look at our scenario. You take B to the bathroom before lying down for a rest. But when you are getting B up for dinner, you notice that he has a new right facial droop and right arm weakness. Because of your training, you recognize that he may be having a stroke. So call 911. The importance of this cannot be overstated. Check vital signs. Note the time that you first see symptoms. A clot-busting medication called TPA, or tissue plasminogen activator, can be given to someone if they're having a stroke, potentially reversing or stopping symptoms from developing, but it has to be given within 4.5 hours of the start of the symptoms. Do not give any medication, food, or drinks. Remember that there are 2 types of strokes, ischemic and hemorrhagic. 80% of strokes are ischemic ones, but if the resident is in that 20% that are hemorrhagic and the stroke was caused by a ruptured blood vessel in the head, you don't want the victim to have aspirin, and you can't tell what one it is until you get to the emergency room and you get some type of brain scan. The biggest thing is recognizing that the resident is having a stroke. So there isn't much that you can do other than stay with the resident. But after you call 911, the ambulance notifies the hospital of the possibility. The ER is ready to receive the patient, and radiology is alerted to be ready for a CT scan. The next subject we're going to discuss is a heart attack. A heart attack happens when the blood supply to the heart is completely blocked and part of the heart muscle dies. People having a heart attack can be pale, sweaty, short of breath, and have severe chest pain. Now, this chest pain is often described as a pressure or as a crushing. And somebody having a heart attack can suffer serious complications and even die if treatment is not provided quickly. Let's look at some statistics. Heart disease is the leading cause of death for men, women, and people of most racial and ethnic groups in all of the United States. In the United States, someone has a heart attack every 40 seconds. And every year, about 805,000 Americans have a heart attack. But it's important to know that 1 in 5 heart attacks is silent. That means that the damage is done, but the person is not aware of it. Men and women can also have very different symptoms. For example, men will often have more of the classic symptoms, so discomfort, tingling in the arms, the back, the neck, shoulder, or jaw. Men will have shortness of breath and kind of those classic chest pain symptoms. But women can have sudden dizziness, more of a heartburn-like feeling in the chest. They can have cold sweats, maybe an unusual tiredness or fatigue, and even nausea and vomiting. So it's important to understand that it can even present differently in different genders. So let's look at a scenario. As you are trying to help H bathe, she starts complaining of left-sided chest pain and a rapid pounding in her chest. The pain feels like a pressure, and she starts to feel nauseated, dizzy, and short of breath. Even the color of her skin seems to have changed. It becomes kind of a gray, pale color. The pain radiates to her left arm and feels like a pressure. Because you have been trained to recognize these signs and symptoms, you correctly assume that she is experiencing a heart attack. At this point, it is important to know the resident's advanced directive status. If that status involves providing emergency treatment, then advance to the next step. And that next step is to get help immediately. If no one is around to respond, you must make sure that the resident is safe and alert someone to call 911, or you must call yourself because time is critical. If someone is having a heart attack, administering IV medications that open the blood vessels of the heart must be given as soon as possible, preferably within 60 minutes from when the signs and symptoms began. Administering these medications will prevent further damage to the heart muscle and can dramatically decrease the risk of death. So in some areas of the United States, the EMS crews actually have the capability to give these sophisticated, complex treatments en route to the hospital. So calling 911 is always the first step. The next step would be, of course, to stay on the scene. Stay with the resident until EMS personnel or other assistance arrives. If there is an automated external defibrillator available, have it brought to the scene. Again, if available, start oxygen at 2 liters per nasal cannula. The nurse may administer aspirin, so it's a baby aspirin, which is an 81 milligram aspirin, if it is available and if it is indicated. And this tablet should be chewed and not swallowed because chewing gets the medication into the circulation more quickly than if the tablet was swallowed. Also, vital signs should be obtained while the above steps are being implemented. If the resident's blood pressure is stable, and again, if indicated, the nurse may administer a sublingual nitroglycerin. This is a medicine that opens blood vessels to improve blood flow. This is used to treat angina symptoms or the symptoms of chest pain or pressure. And that happens when there's not enough blood flow to the heart. And at any time the resident becomes unresponsive, stops breathing, or goes into cardiac arrest, the medical team will initiate the correct emergency procedures. The next subject we're going to discuss is acute abdomen. Abdominal pain is the most common emergency department complaint and the 4th most common complaint among elderly patients. The physiologic, pharmacologic, and psychosocial aspects of elderly patients make evaluation of their abdominal pain different from the general population. And unfortunately, this population is prone to worse outcomes, higher rates of admission into the hospital, surgical interventions, and prolonged emergency room and hospital stays. Alarmingly, death in patients greater than age 80 with abdominal pain nearly doubles when initial diagnosis is delayed. Again, this is why it's important to recognize symptoms early. Acute abdomen is a general term used to describe sudden onset and severe abdominal pain. There are many conditions that may or may not require emergency surgery to treat, which is why it is important to be able to quickly identify the cause. So really, the signs and symptoms depend on the cause, but they may include sudden onset of abdominal pain, well, of course, nausea and vomiting, fever. Their abdomen may be tense, rigid, distended. They may have other signs and symptoms like tachycardia, which is a fast heart rate, low blood pressure, constipation, or the opposite, diarrhea. They may have a refusal to move because of pain. They may have rapid, shallow breathing. Now, there can be many causes such as infection, inflammation, maybe a bowel obstruction, gallbladder disease. There can be a vascular occlusion, maybe appendicitis, a peptic ulcer disease or a ruptured ulcer, diverticulitis, acute pancreatitis, constipation, and even cancer, a malignancy. So really, treatment depends on the cause. But because some causes of abdominal pain are life-threatening, triaging residents quickly and accurately is crucial. Now, other nursing interventions are going to include ongoing assessments, managing the patient's pain, providing emotional support, restoring fluid and electrolyte balance, and specific intervention to treat the pain's underlying cause. So let's look at our scenario. You notice that G, a 77-year-old man with Alzheimer's disease, has not been eating well over the last few days. As you try to coax him to drink fluids at lunch, he starts to vomit and doubles over. You bring him back to his room, get him cleaned up, and lie him down in his bed, but he curls up into a fetal position and doesn't want to move, and he's clutching his abdomen. Because of your training, you recognize that he's having abdominal pain. Get help immediately. If no one is around to respond, you must make sure that the resident is safe. If appropriate, with the resident's advanced directive status and the nurse confirms that it is necessary, alert someone to call 911 or call yourself. Also, quickly check vital signs. And again, treatment depends on the cause, so the focus is to get the resident cleaned up and make them comfortable, including interventions such as positioning, back rubs, maybe even heating pads if appropriate. The nurse will evaluate the resident and administer medicine for vomiting and or pain if appropriate, and may start an IV to start fluids if necessary while waiting for emergency medical services to arrive. Our next subject is acute glaucoma. Now, this is a serious eye condition that occurs when the fluid pressure inside the eye rises quickly. It is an emergency because if it is not treated quickly, it can lead to permanent loss of vision. About 1 in 1,000 people develop acute glaucoma in their lifetime, so it is rare. But the thing is that it is much more likely in people over the age of 40 and most often happens at around the age of 60 to 70 years of age. Now, it is more common in long-sighted people and in women, and if somebody has a close relative that has had acute glaucoma. They think this is because they may have an inherited eye shape, which makes acute glaucoma more likely. Now, in people who are prone to acute glaucoma, there are some situations that may trigger it. For example, acute glaucoma is more likely to come on when the pupil is dilated. So this may be while watching television in dim light, during stress or excitement, or even at night. Some medicines can also trigger acute glaucoma in people prone to it, as can being under general anesthesia in older people. So commonly used medicines which may trigger acute glaucoma are the eye drops that are used to dilate the pupil, which are used for eye checkups, certain types of antidepressants, so like the tricyclic antidepressants or the SSRI types. There are other types of medicines like anti-nausea medicines, the ones that keep people from vomiting, those that are used to treat mental health conditions such as schizophrenia, others used for asthma. One that we're cautious in using is called topiramate, that's used for migraine and epilepsy. And some medicines used to treat allergies or stomach ulcers. So there's some examples there. Signs and symptoms come on very quickly and they can't be ignored. They include eye pain, severe headache, nausea or vomiting, very blurry or hazy vision, seeing rainbows or halos around lights, redness in the white part of the affected eye. The pupils can be of different sizes. There can be a sudden loss of sight. Symptoms will continue to worsen unless treated, and the resident will need to see an eye specialist or an ophthalmologist. Now, the diagnosis can usually be made from the symptoms and the appearance of the eye. And a primary care physician can usually make that diagnosis, or an eye doctor or an emergency room doctor. The diagnosis would be confirmed by an ophthalmologist or an eye specialist. And this usually involves examining the eye through a special light and a magnifier called a slit lamp and measuring the pressure in the eye. The treatment involves medications that lower the pressure in the eye in the form of different combinations of eye drops and injection into the eye, or even IV medications. But laser and surgical or surgical treatment may be necessary. The good news is that the outlook or the prognosis is good if treatment is started quickly and the eye can recover, and laser treatment or surgery can prevent the problem from actually coming back. All right, let's look at our scenario. R is at craft time, and as she is trying to cut out magazine pictures, she complains that she has a horrible headache, right eye pain, and can't see out of her right eye. She asks to be taken back to her room because she feels nauseated. But when you look at her eye, you notice that it looks red. When you ask what time the headache started, she says it came on suddenly about 20 minutes prior. Because of your training, you recognize that she may have acute glaucoma and that she needs to see an eye doctor right away. So you should alert the nurse right away. She will alert the resident's eye doctor for further instructions or arrange transportation to the nearest emergency room. Now, what you should not do is try to cover the affected eye with a patch or a blindfold. If you do this, the resident's pupil will dilate further, and this can worsen the situation. You also should not allow the resident to lie down in a darkened room. Lying down can tend to raise the pressure in her eye still further. A darkened room will further dilate the pupil. And the last thing to do is keep the resident calm. Ask the nurse if any pain medication is available to the resident, because stress can make the pressure worse. The next subject we're going to discuss is more of a symptom, and this is shortness of breath. Shortness of breath or breathlessness is common in people with serious or advanced illness. It makes breathing difficult and uncomfortable. Now, it can be caused by many things, problems with the lungs or with the heart or by a low blood count, but its specific cause can sometimes take a while to pinpoint. Signs of respiratory distress would be an increased breathing rate. So this is when people have more trouble breathing. They take more breaths per minute to compensate. They can have their nose flaring. So if a person opens their nostrils wider with each breath, this could indicate that he or she is having to work harder to breathe. They may have color changes. If you see a bluish color around somebody's mouth, on the inside of their lips, or on the fingernails, he or she may not be getting enough oxygen. The color of the person's face may also appear pale or gray. They may have grunting. Sometimes you may hear a person in respiratory distress making a grunting noise during each exhale. This sound is the body's way of trying to keep air in the lungs. Victims of respiratory distress may have sweat on their heads and their skin feels cool or clammy to the touch. This can happen when the breathing rate is very fast. They may have wheezing. So if you hear a tight whistling sound with each breath, this could indicate the air passages may be tighter than usual. They can have retractions. A retraction is when a person's chest appears to sink underneath the breastbone or under the neck with each breath. This is one way the body brings more air into the lungs and can also be seen under the rib cage or in the muscles between the ribs. So let's look at a scenario of shortness of breath. You are passing by a resident room when W calls out. You enter his room and he is barely able to tell you that he can't breathe. You notice that his breathing is shallow and rapid, and he is also developing a bluish color around his lips. Because of your training, you recognize that he is short of breath. So, of course, you get help immediately. If no one is around to respond, you must make sure the resident is safe and alert someone to call 911 or call yourself, of course, if the advance directive indicates it. Quickly check the resident's airway for obstruction and check vital signs, including a pulse oximetry. Elevate the head of the bed. When a resident is having difficulty breathing, Fowler's position can provide relief. Now, when sitting in Fowler's position, the client is upright at 90 degrees, allowing the chest to expand as much as possible. Prone, which is on the abdomen, or supine on the back, or lateral on the side, are all flat positions, which can make respiratory distress worse. Place the resident on supplemental oxygen, pulse oximetry, and a cardiac monitor if those are available. And the nurse will evaluate for the cause of the respiratory distress and administer treatment as necessary while you are waiting for emergency medical services. The next subject we're going to talk about is anaphylaxis. Now, anaphylaxis is a severe, potentially life-threatening allergic reaction. It can occur within seconds or minutes of exposure to something a resident may be allergic to, such as peanuts or a bee sting. And again, if not treated right away, usually with epinephrine, it can result in unconsciousness or even death. Symptoms of anaphylaxis include skin reactions, including hives and itching and flushed or pale skin, low blood pressure, which is also called hypotension, constriction of the airways and a swollen tongue, face, throat, which can cause wheezing and trouble breathing, a weak and rapid pulse, nausea, vomiting or diarrhea, dizziness, or fainting. So let's look at our scenario. H was outside in her wheelchair in the garden. She was stung by a bee and comes in to call for help because she is allergic to bee stings. You notice her face is swollen and she has a rash on her skin. She is also starting to wheeze. But because of your training, you recognize that she is having an anaphylactic reaction. Get help immediately. If no one is around to respond, you must make sure that the resident is safe and alert someone to call 911 or call yourself. Obtain vital signs and pulse oximetry. If the patient has an antihistamine, get it ready and the nurse will decide to give it. Now, if an epinephrine auto-injector, which is typically called an EpiPen, is available, get it ready and the nurse will decide to give it. And then stay with the resident until emergency medical services arrive. And depending on her response to the EpiPen and maybe even an antihistamine, they may decide whether or not to take her into the emergency room. Seizures are also a major issue for residents in nursing homes. This medical condition is caused when an abnormal electrical discharge pulses through the brain. In some cases, these seizures can cause convulsions in the body, life-threatening complications, and a change in mental functioning. Why do seizures occur? Although seizures are normally associated with epilepsy, they can be caused by various medications and health problems. If the individual is ill, a high fever can cause a seizure to take place. Additionally, seizures can take place after an accident or major trauma, and individuals may develop a seizure due to a brain tumor, stroke, sickness, or surgery. Before a seizure, the individual may stare off into space or have a change in awareness. Their sense of smell or taste may be altered, and they may have a strange taste in their mouth. Other signs of an impending seizure include convulsing movements, a tingling sensation, twitching muscles, or confusion. And the individual may feel a sudden unexplained fear and anxiety as the seizure starts. So let's look at a scenario. You walk by M's room and you notice that he is shaking, goes unconscious, and falls partly out of his wheelchair. He is having rhythmic movements of his arms and legs, and you note that he has been incontinent of urine. Because of your training, you recognize that he is having a seizure. When most people think of a seizure, they think of that generalized tonic-clonic seizure, also called a grand mal seizure. In this type of seizure, the person may cry out, fall, shake, or jerk, and become unaware of what's going on around them. So stay with the resident and call for help. Note the time and be sure the nurse is notified. If the resident is in bed, raise the side rails if present. Turn the resident's head to the side or place the resident in a sideline position and remove the pillow. If the resident is out of bed, gently lower the resident to the floor. Turn the resident's head to the side or place the resident in a sideline position to open the airway and promote drainage of secretions. And protect the resident's head with something soft and flat like a pillow, a blanket, or a folded jacket. Move hard objects out of the way as appropriate, or pad around the bed and or objects that might cause injury during a seizure. Provide privacy by asking onlookers to leave and closing doors or closing the curtains, and do not attempt to restrain the resident. So observe for changes in the resident before the seizure, such as some type of visual or auditory aura, so something that they saw or that they heard, any confusion, any staggering, or any behavioral changes. The time the seizure started and stopped, and the duration of the seizure. A description of the body parts involved and the severity of the convulsive movements. The presence of an aura, incontinence, unconsciousness, eyes rolled upward, frothing of the mouth, biting of the tongue, or injuries due to the seizure, and the condition of the resident after the seizure, such as being confused or disoriented or sleepy. Now, seizures do not usually require emergency medical attention, so only call 911 if one or more of these are true. The person has difficulty breathing or waking up after the seizure lasts longer than 5 minutes, or the person has had another seizure soon after the first one, or the person is hurt during the seizure. An asthma attack is a condition in which a person's airways become inflamed, narrow, and swell, and produce extra mucus, which makes it difficult to breathe. There are approximately 2 million patient visits to emergency rooms because of asthma attacks, and over 500,000 patients are admitted to hospitals for the treatment of asthma. Asthma attacks are typically caused by a trigger such as an exposure to cold, dust, emotional stress, or a respiratory infection, and asthma attacks can range from mild to life-threatening. The symptoms of an acute asthma attack include a cough, which can occur at night during exercise. It can be chronic, it can be dry, it can have phlegm, it can be mild, or it can be severe. There can be respiratory symptoms such as difficulty breathing, wheezing, breathing through the mouth, and even rapid breathing. Also common is chest pressure, flare, anxiety, early awakening, fast heart rate, or throat irritation. So let's look at our scenario. S has been experiencing allergy symptoms for the past 2 to 3 days. However, this morning, as you are getting her ready for the day, you notice that she is having a persistent dry cough and wheezing. She also complains that she wasn't able to sleep well the night before because of it. She also seems to be breathing fast. Because of your training, you recognize that she is having an asthma attack, and you know that she has a history of asthma. Get help immediately. If no one is around to respond, you must make sure the resident is safe and alert someone. Most residents with asthma should already have an asthma action plan in place. So it would be helpful to get a peak flow assessment. A peak flow meter is a handheld device that measures how well air is moving in and out of the lungs during exhalation. Then usually some type of a bronchodilator is used. So this would be a rescue inhaler or a nebulizer treatment, which includes a bronchodilator, which is usually albuterol. And this quickly dilates the constricted bronchial passages. And again, the asthma action plan contains instructions that should be followed on this. Now, the nurse will alert EMS at any time as appropriate. Finally, we're going to discuss low blood pressure or hypoglycemia in a diabetic. People with diabetes need oral medication or injectable insulin to keep their blood sugar at a safe level. Hypoglycemia or low blood sugar occurs when the blood sugar drops below 70. And because the brain essentially can only use blood sugar for energy, permanent brain damage can occur if hypoglycemia is not quickly corrected. So let's look at some of the symptoms of hypoglycemia. So the causes include too little food, or maybe somebody has skipped a meal, or they've had too much insulin. It usually happens suddenly. People can feel shaky, their heart beats fast, they get sweaty, dizzy, anxious, hungry. They get blurred vision, they can feel weak or fatigued, they can get a headache, they can get irritable. They can also have mental status changes such as confusion or disorientation. So let's look at a scenario. V is a known insulin-dependent diabetic resident. In the past few days, she hasn't eaten very much during her meals. The nurse checked her blood sugar before breakfast and appropriately administered her insulin. However, she only ate her eggs for breakfast. Soon after, you notice that she seems confused and anxious and appears shaky and weak. Because of your training, you suspect that her blood sugar is low. You ask the nurse to check her blood sugar, and it is only 59. So what should you do? If the resident is awake and conscious, give some form of easily digested sugar, such as candy, juice, fruit, or even table sugar. Many residents who have diabetes carry glucose tablets or glucose gel, and these should be given if they are available. If the resident won't cooperate, don't try to force him or her to eat. People who are hypoglycemic are often confused and they don't know what's happening, and they become irritable or aggressive if you insist they eat or drink. Remember, the first rule of responding to medical emergencies: don't hurt the resident and don't hurt yourself. If appropriate, the nurse will administer a glucagon injection. This is a naturally occurring hormone that stimulates the liver to release glucose and raises the blood sugar. Do not give someone who is hypoglycemic and unconscious food or fluid. And if the patient, of course, is severely symptomatic, you're going to need to call 911. In conclusion, it is essential to notice and report change in a resident's condition, and it is everyone's responsibility to do so. Staff should know how to recognize and to respond appropriately to emergent situations. A long-term care facility has the legal responsibility to provide necessary care, and a claim shortage of staff or money is no excuse. In instances of litigation, it will need to be proven that the staff followed all the necessary emergency protocols to prevent resident harm and preserve life. Thank you so much for listening to this teaching. I hope that you learned a lot. And now it is time to take your quiz.